Good evening, everyone. Thank you for coming to the HOSC meeting tonight. Have we any apologies?
Councillor Turtle.
And Mary-Louise, you're substituting. Thank you very much. We've got some officers already online, and we're not all here yet, let's hope. The minutes of the previous meeting. Are you happy that I signed the minutes of the previous meeting as a correct record of the meeting?
Shona.
He's substituting.
Shona.
Mm-hmm. Sorry, can't hear you.
Fraser seemed to like it too. His tail was wagging.
He's the mindfulness dog, so if you need a cuddle.
He hates the bang bangs at this time of year. He's very attentive.
Are you happy that I signed the minutes?
Yeah.
Yeah, thank you. Madeline, do we have any public question time?
No questions.
Thank you. Do we have any member questions?
No.
Winter pressure preparedness. Who's going to present this? Ingrid?
Evening, Chair. So I think there's two parts to this. So I think Hannah and Helen from our ICB colleagues will be presenting the bit around the sort of formal unified exec preparedness, and then I will add to that with some of our more local Wokingham specific work that we've done, if that's okay.
Okay, that's lovely. Thank you very much. Would one of you like to go ahead then, please? It's on page 11 of the agenda and it's quite a big document.
Thank you, Chair. Just by way of introduction to colleagues this evening, my name's Hannah Mills. I'm Director of UEC and EPRR for Bob Integrated Care Board. So as you've reflected, we're just here this evening to present our winter planning and preparedness activities to put us in the best possible position to mitigate and address those higher demand associated with seasonal demand and particularly winter in this instance. I reflect entirely that it is a considerable size document that we've shared with you for completeness that does look to present really our learning from last year, also to provide a sense of the activities and arrangements for 7-day oversight through NHSE and locally how we're adopting that. But I think there are a few key slides that I'd like to draw the committee's attention to, which is where I will concentrate my efforts this evening, just in terms of providing assurance of the activities underway to put us, as I say, in the best possible position to manage winter and the associated pressures with that. So if I can suggest, I'm very happy to take questions on any other items, but if I suggest we just start on page 20, which really looks at the demand capacity initiatives. And I must just, I guess, preempt some of this, that this is all building upon the existing and established UEC programmes of work to really ensure that there are suitable alternatives to emergency departments for our patients who can safely and appropriately be managed in a home setting or in a community setting, and also recognising that this is part of not only the national UEC recovery plan, but also what's referred to as high impact initiatives. And those are really 10 areas where nationally there is real priority and clinical evidence to suggest that if we have those services up and running, we will see much better utilisation of community services, avoiding, as we've said, ED attendances and admissions where it's clinically appropriate and safe to offer an alternative, and also meaning that those who really need to access emergency services within an acute setting are able to do so, and as a consequence have less time to wait until they are seen triaged and either admitted or discharged from the emergency department. So I think as it's reflected in the sort of learning page, this is all about really how we have planned for the full year and taken winter into consideration as part of that annual planning and programme development. So if I take us to slide 20, so page 20 in the pack. So all of these areas fall under the high impact initiative. So the community crisis response, that's a long-standing service, but this is really saying that if somebody is deteriorating, has their clinical condition deteriorating in the community, that a referral can be made by a healthcare professional, and there is a response, a timely response by the community teams to enable to stabilise their condition and manage next steps or provide further intervention as they require. So I think a real key area of this is recognising that we are increasing the capacity and have increased the capacity as part of our annual planning programmes, and we are really doing really well in terms of meeting the trajectory for the number of referrals that we are receiving through that service. So that's sort of a key first area. Virtual wards, it's otherwise known as hospital at home. So we recognise the term virtual wards may not be very friendly to patients and users of the service. This is really ensuring that you are getting a hospital level support and care package in your home or residential setting. And we've seen some really positive work in this area. It not only supports admission avoidance, it also supports more timely discharge of a patient in an inpatient setting, whether that be a community inpatient bed or an acute bed. There is an opportunity for that patient to be safely discharged with some ongoing care in their home or residential setting. Single point of access is really recognising that there are a huge amount of services available to healthcare professionals and allied professionals, but sometimes it's not terribly easy to navigate. So there has been a lot of work done with colleagues to ensure that we simplify the process, and that regardless of the sort of type of service or what we call a service, there is a single point of access whereby a referring clinician can call a number and discuss a patient's needs with the service, and the service will then navigate that patient and that professional to the most appropriate care setting to meet those clinical needs. So that's something that we've really worked hard on, not only across the Berkshire West partnership, but recognising the benefit of this across the ICS and wider system as well. And really that is so that we can, as I say, optimise utilisation of those alternatives to hospital, reduce admissions where appropriate to do so, and making sure that we're docking patients into the right service to meet their needs in a more timely and effective way. And that's particularly with regards to services such as same-day emergency care. I'll hold on to same-day urgent access just for a bit, but if we look at other services that we've got established, these are all established, as I say, already within Berkshire West. These are current offers, but just recognising that these services will be integral to our response to winter, and as I say, that additional seasonal demand. Clinical assessment service is really providing additional primary care capacity from 111. So anybody that calls 111, if they have a primary care need and their practice is unable to meet that need during core practice hours, this service is able to assist. And again, it will meet any of those minor illness requirements. And as we've seen, we've got a really high success rate of the number of cases that can be addressed and fully resolved without needing to go back to the patient's own GP. So we've got that in place, that remains in place, and that will be available throughout winter. We've also got West Call redirection, so this provides additional capacity at the site of the ED at Royal Berkshire Hospitals to make sure that, a bit to our earlier point, is making sure that we've got the appropriate service for the clinical needs of a patient. So where a patient is presenting to an accident and emergency department but doesn't have high acuity needs, so doesn't warrant the expertise of emergency practitioners, they can be supported in their minor illnesses that may be more akin to primary care. Day-to-day services can be provided through the West Call offer. So that again is another mitigation we've got to reducing overcrowding in ED and providing a more timely response to the 4-hour standard. Flow and discharge, it remains a key area. We know that if we can discharge patients, that will help the front door as well. And we talk about that. There's a lot of publicity about that in the media as well. That remains a key area of focus. And we've got established processes in place with local partners to ensure that we are optimising discharges as soon as a patient is becoming ready for being discharged, but also looking ahead. So on admission, starting to have the conversations about when a reasonable and robust discharge date might be emerging. So having those conversations really, really early on so that we can put in place any support packages or anything else that might be required to facilitate that timely discharge. Community bed utilisation. This is recognising that we do have community bed stock available to us to support those patients with a sort of intermediate level of care need, and that's whether it's a step up requirement or a step down. So step down coming from an acute or a community offer for somebody who might otherwise be in their home and just needing that additional level of support. There's been, again, extensive amounts of work to ensure that we are absolutely optimising the capacity and resource available through those community beds as part of standard practice, but recognising that that becomes a really key enabler for us to meet front door demand if we've got that backdoor flow happening well during those winter months when we do anticipate an increase in demand. Aligned with that is recognising that there is real benefit in making sure that we've got good flow and good work over weekends as well. So moving really towards a 7-day offer in terms of community bed utilisation. If I come back to the same day urgent access, so this is just to reflect that we have an interim solution in place. So we have introduced an interim pilot UCC at the front door of Royal Berkshire Hospitals, whilst we maintain the Broadmal offer as well throughout the winter months. So that will provide us with additional capacity over those winter months and face-to-face appointments 7 days a week, which is really intended to support ED and really provide a more appropriate and suitable alternative to ED for those presenting with minor illness. So that's also in place as part of our same-day access programme. I've talked about timely and effective discharge on slide 23. Just to touch on the work that we're doing absolutely with our adult social care partners and our voluntary sector partners, there is additional work for the winter months that has been agreed. So that includes, as you can see outlined, additional staff within the discharge teams for adult social care, carers response service, health homes assessor, and discharge to assess beds. So all of those things we have worked very closely with our adult social care partners with, including increased brokerage support and social care resource in ED. Equally, there is a long-standing and very established working relationship with the British Red Cross on the prevention of admission to hospital, and that absolutely is maintained and fully staffed ahead of winter. So that's been really positive as well. We're just looking to see if there's any desk space at RBFT to further enhance that joint working arrangement so that they are on site and available during those winter months. Chair, I'm more than happy to take any questions. I'm conscious, as I say, there is a lot of detail in the pack. A lot of it is more for contextual awareness. I believe I've covered off particularly the work that we've got in train to support winter, in particular as part of our annual planning and UEC programme and priorities. But if there are any questions from colleagues, then
Hannah,
please.
could I stop you for a moment? Because we've got very different headers to you on our paperwork, and so it's more difficult for us to follow. And Rochelle, did you have a question?
There are 3 terms that you've used here that you haven't explained or defined: SPOA, shrewd, and opal. It's very nice to see these terms, but we don't know what they mean, and you haven't explained them in the paperwork any place that I can find.
Apologies.
It would have been quite nice to have a list of acronyms.
Yes.
So that we could look them up. Yeah,
very happy to address those points. So the SPOA is the single point of access. So that's the term, the shortened version of that naming convention. So that goes back to that having that single point of access into available to healthcare practitioners to ensure that any patient needs are navigated and referred to the most appropriate service. So that's the single point of access. Shrewd is the name of the platform that we use that provides real-time data on what's happening within our units and within our urgent and emergency care services. So for example, it will say how many people are in an emergency department at any one point. So that's reference to that that platform's name. And with regards Opal, it's an operational pressures escalation level. It's part of a national framework that effectively has consistent indicators and triggers to provide an indication of the operational pressures emerging. So we have long-standing Opal frameworks that are in place at trust level, and they will cover all manner of service areas. But last year, nationally, they introduced a national Opal framework specifically for acute trusts and urgent and emergency care within acute trusts, which comprises of 9 indicators, which results in a score, and that score is then comparable across trusts and across regions and nationally to give an indication of the relative level of pressure against those 9 indicators. This year, they are introducing an Opal framework for community services, mental health services, and in January, we're anticipating an Opal framework for 111 services as well. All of those will come together to provide a consistent mechanism for appraising operational pressures across those service areas.
Hannah, do you want to take questions as we go along or at the end?
Yeah, by all means. I was going to leave it there, Chair, just in terms of the areas that I was going to pick up in terms of particular activities for winter, but I'm very happy to take any other questions or if there's any other lines of inquiry that colleagues would like to flag.
We've got one question from Shahid.
Thank you, Chair. Thank you for the presentation. There's a lot there to unpack, actually. But there's one particular things I want to look into, and that is the timely and effective discharge.
Mm-hmm.
I was reading a report, a BBC report, where actually it gives some figures. Anything between 300 to 500 million pounds is costing the NHS because the discharges are not happening within time. Therefore, they end up staying, occupying the beds.
Mm-hmm.
When actually the support, if the support was available in their homes or in the community,
Yeah.
that could be a huge saving to the NHS, right? So you mentioned that is in, obviously you're working with the partners, but my understanding is, I was looking into this, is it seems to have some bit of bottleneck as well. So what are we doing? Probably what steps are we taking to make sure that actually the patients are discharged in a timely and effective way? Obviously, it makes a lot of financial sense as well, right? So I'm sure there's a lot of other providers who are willing to provide the service, but my understanding is that the discharge, the whole process of discharging is not happening in a timely and effective way. Perhaps if you can, maybe explain that further.
Yeah, absolutely. Really happy to. As you rightly say, discharge is a really, really key area of concentration because we recognise that it's part of that wider flow. And unless we get timely and appropriate discharges, we're not going to be able to accommodate and bring in people through the front door at the level that's required. So absolutely, you can't look at one without the other. So you're absolutely right. It's all part of that flow. And rightly so, there's been a lot of interest in that and how systems perform when we're looking at the timeliness of those discharges. There are a couple of key areas that I would frame in terms of our response and how we're working with partners to address that. There has been the introduction of what are referred to as transfer of care hubs. And these are hubs that have line of sight of patients who are ready for discharge and are concentrated on ensuring that whether it be a care package, whether there are arrangements put in place to facilitate that patient's discharge in a much more timely manner. And that it comprises of all partners involved in those conversations. It is very much a multidisciplinary team approach to discharges across acute, community, adult social care and voluntary sector, care homes, etc., to support that. So the transfer of care hubs have been introduced probably about 3 years ago now as a concept. We have transfer of care hubs across all of our BOB providers and systems, which is really positive, and particularly in Berkshire West, Royal Berkshire and Berkshire Healthcare work very closely with us and adult social care to ensure through that transfer of care hub arrangement, we are proactive and have line of sight of all of those patients, so can take more proactive action through those routes. I think the other thing I would flag is as a sort of we're looking to bring the whole conversation further and up front in the pathway. So as somebody is admitted, we're having the conversations about, we're admitting this patient today, but when do we think, given their clinical circumstances, clinical complexity, when do we think at this point it might be a reasonable expected discharge date? So is it 3 days? Is it 5 days? Are they going to be with us for a little while because they've got really complex health needs and are significantly unwell? So that as part of that, we've kind of got the forward view of what is going to be coming up as well, so that we can look and track and again proactively intervene in managing the timely discharges of those patients. So all of that is effectively established as what we would refer to as business as usual, and that is all underpinned and supported through the regular meetings that our respective teams have together to do that review, to look who's coming up, to really ensure that we're interrogating and understanding if we've got a delay, we're clear on the cause of that delay and what action needs to be taken, and we can escalate appropriately if needed as well. But all of that is part of as I say, what we would refer to as business as usual, but just recognising that it's even more important during those winter months to have that truly embedded so that we are optimising that flow given the increased demand at the front door. Does that answer? Have you got a follow-up?
Yeah, can I come back, Chair, if I may? Yeah, thank you for the response. I'm just thinking that, obviously there's a multidisciplinary assessment you talked about.
Yep.
Then obviously there are providers to see whether the providers who are willing to or have the capacity to provide that service of care which is required. Just from my understanding, and I'm sure it'll be useful to the rest of the members here as well, where is the problem? Where is the bottleneck? Is it the multidisciplinary assessment is not happening in in the timely manner? Or is it actually we don't have enough providers in the market, therefore we cannot actually release the patients to provide the care? So I'm just trying to understand where is the bottleneck?
Yeah, and I don't think there is a single bottleneck. I think it is a really complex area and there will be different contributing factors in different cases. So for example, there might be a period of time where we're seeing a real increase in the number of really complex discharge requirements. So these are sort of pathway 3, those that need significant care packages to be supported in a place of residence. Or a care home placement. They can be difficult and complex, whether that's because of the medical requirements, because of the market. There are all manner of different factors that influence that. There may well also be just a period where you have an increase in discharges because everybody's sort of discharge date has come up at the same time, and how do we work together to ensure that they are continuing to be moved and supported through the system, etc. So I don't think there is a single cause. I think it's multifactorial, and I think the purpose of the transfer of care hubs and the work that we're doing across the partners is ensuring that we are all sighted and clear on our respective roles and responsibilities in supporting individual patients who are ready for discharge and whatever their discharge location might be.
Thank you, Hannah. Adrian has a question for you now.
Thank you, Hannah. Looking at the documentation around Shrewd looks like an IT investment by the ICB, which is good, and it's helping to understand, let me call it pipeline for the individual trusts, and it's giving access very much from only the trust perspective. And what I would like to see is really Shrewd Mark II, which is, going deeper and into a more granular level, looking at the cases that are in adult social care that may be coming to RBH, or wherever the source of the entry point to RBH is, that you capture all of that. And conversely, and you started to talk about this, sort of planning for the exit, and that includes closing the loop with, Woking Borough Council or Reading or whoever, when that person is exiting, so that the council is aware that that person is getting better in the hospital environment and is likely to be discharged in 5 days or 10 days or whatever it is, so that we have, the fully closed loop between all partners. That would be my ideal scenario. But I know it's a difficult ask, because you're extending the usage of this kind of platform and the functionality. But I think it will be helpful to everybody if everybody had foresight on what's coming our way.
Yeah, absolutely. And I absolutely agree in terms of having that foresight and that shared platform for information. What it's probably important to highlight is, in the context of Shrewd, Shrewd is an operational pressures tool. It is not a clinical tool. But having said that, I do think there are other tools available to us which we are mobilising throughout Thames Valley and within Bob. Things like the shared care record, so that all of those involved in a patient's care can see the plan for that patient, what we need to do, any interventions that they are receiving from any of the partners, etc. So we have those tools available to us from a clinical perspective in terms of shared access to records. But I completely take your point about there being other things that maybe neither of those tools do completely in isolation. I think it would be for us to explore through the combined exec about what that might look like. So within Berkshire West, we do have our UEC programme board, which absolutely looks at these sorts of opportunities and where we are identifying blockers, how as a collective we might look to address those. So I think that is something we can absolutely take back to the Berkshire West UEC programme board for further consideration. One, to do the sort of baselining and assessment as to whether or not we have access through that, through our local operating arrangements already, but if not, what would be the vehicle for doing that, and is there the shared ambition and opportunity for us to invest in that across the partners locally.
Obviously, the question is to minimise the number of telephone conversations that have to happen when a patient is transferred from one entity to another entity. If there's an IT system which is recording this, you can reduce the number of conversations dramatically. I'm not saying reduce all conversations, but with the best will in the world, it probably takes 5 or 10 conversations when a person is being moved from one entity to another entity. If that can be reduced by, I don't know, 60% or 70%, then that means the whole system becomes more effective and more efficient and slicker and quicker. Yeah.
Completely agree, and that is absolutely the opportunity that the Thames Valley Shared Care Record affords us. Yep, and I know colleagues are working really hard to really make sure that that's rolled out and mobilised and used effectively by partners for exactly that purpose.
Thank you. Alice, you have your hand up.
Thank you, Chair. Thank you, Hannah, for the presentation. Just as HealthWatch, we hear a lot of the time that the families are not involved in the conversation. So when do you bring the families in? Because they also part of this.
Yes.
So, that's the one thing that, a lot of families say we only get informed late in the pathway. So, it'd be nice to understand where they are brought in. That's one. The other thing is also, we've also been informed, I don't know how far this is true, part of the block is because of the continuing healthcare. That has got something to do with it as well, the funding.
Okay, Alice, that's really helpful. So let me take the first point first. So in terms of engaging friends and family, I couldn't agree more. I think it's absolutely imperative. And I think we have done a lot of work. That's not to say we couldn't do more work. But I think that's particularly where we can work with HealthWatch and also other voluntary sector organisations to gain that intelligence and soft intelligence we are hearing from patients and relatives about their experience and whether we are succeeding in our endeavours and our ambition to involve family in those decisions. I think we have improved our literature around discharges and what to expect. there may well be more work to be done, but certainly through that transfer of care hub and having a dedicated resource and team to support, we're, I think, better positioned to ensure that there is effective and wider mobilisation of some of those activities to ensure that we are consistent and offering, as you rightly say, family notice and engaging them in those conversations. So yeah, I think it happens. Well, I know it happens. Let me reframe that. I know it happens, but I think it's really important point, and one that we need to keep a watch on through our agencies, but also through patient feedback directly as well. Yeah. The other point you mentioned about CHC, I'm not aware of any immediate bottlenecks with CHC. I'm not aware of those, so I'm sorry, I just can't comment directly on that, but I'm happy to take it away and certainly liaise with colleagues on that to establish whether we are aware of any known issues. I'm not at this point, but CHC is not part of my portfolio, so I don't want to provide any misinformation in error here. It's not something I'm aware of that is a particular issue in Berkshire West.
Chair, can I come back to one of the questions?
Yes, Alice, of course.
Thank you, Chair. It's one of the things that we have been very aware of is the documentation, the pathway, and is the language that people use.
Yes.
It's a lot of the language is very much medicalized language. So I do think there's an element whereby we need to work at easy read materials, people that people can understand the pathway, because it's not anything that is medical is not easy to understand. So I do think there's a lot of work that needs to be done when it comes to the material that we've got.
Absolutely. And
Thank you, Chair.
Where we have got patient literature, we're always really keen to test that. So we'll just again ensure that through our partners, we're reiterating the importance of that. Absolutely.
Would you like to go on, Hannah, please?
It's just really, Chair, whether there's any further questions or queries from colleagues.
Chair. Hannah, firstly, that was a brilliant presentation. I was going through to find something being an NHS background, but it looks fantastic. And it looks like it's addressing majority of the concerns our residents face. But I have a few questions which might be interlinked one another as well. The first one is, in slide 17, there is a mention about increasing the appointments for 6,400 per week. So how are we getting on with it? And I also see there are, during winter, you're increasing the appointments in multiple places, like as an example, the Broad Street Mall and a few other places. So how are we communicating those things to the patients?
Yeah, absolutely. Can I take your first question, your first point just around the delivering the 40,000 extra patient contacts? I think it's just important to flag that that was a national government ambition. So obviously there are within our region a need to increase as well. It is more around elective care than urgent care. So I'm afraid I'm not able to respond to that direct query, but I'm very happy to take it back and we can provide an update by email, maybe to the committee with Helen as well, just to let you know what the latest Bob position is on that. So apologies for not being able to respond to that question specifically. Just in terms of the other questions, sorry, could you just repeat? It was about the appointments for other same-day services, was that it?
Indeed, yes, yeah. So where you're increasing the number of appointments, or you're providing some alternate places as well. So how are we communicating that with the residents? Or
Thank you. So I think it's really important to reflect that some of the additional capacity that's being put on board is really to address and manage existing demand. So this is recognising that some of the opportunity for us to manage demand and patient attendances in a slightly different way to better meet their care needs with a benefit on improving waiting times in hospitals, that is around the UCC at the Royal Berkshire. That's the intention. So it's really, as I say, managing and streaming patients from the ED, from the front of the trust. The other areas where we've got Broad Street Mall, again, that was intended to meet, again, that unmet demand that would otherwise maybe be presenting in a GP practice. I think from the evaluation we've undertaken about the type of presentations that go to the Broad Street Mall, it's not had the intended impact as it had maybe originally been envisaged. So we have seen a number of patients who walk in, maybe by virtue of it being there and available. So it's difficult to know whether those patients would have had their health needs met by their GP practice, had that service not been there, those sorts of areas that we're looking into. So all of this is combining and making sure that whether through a GP practice or through 111, which is kind of the front door to the NHS when it comes to same day demand, 111 can triage a patient's clinical needs and then direct them to the most appropriate setting and service to meet those clinical needs. So that may be a minor injuries unit, that may be their GP practice, it might be an urgent care service or an ED, to mention some. So I think it's really important for us to make sure that we have sufficient capacity in services to meet the demand of our population and make sure that we're making those accessible through 111 as the front door to same day services. And that also, I should say, includes our pharmacy colleagues as well, who are absolutely integral to supporting some of those self-managing illnesses, so like the sort of typical winter pressures of colds, etc. So they are absolutely key partners in this as well.
Can I follow that up on 111, please? Because in my experience, and I don't have a huge amount, you can sit on the phone for a good hour before you get a reply from 111, and that certainly isn't the service that I think you're providing.
Yeah, I mean, we recognise that performance for 111 could be improved. We also recognise, however, and I completely accept that this is not appropriate for all patient cohorts and communities, but there is also 111 online, which has been used a lot by the public as well. So there is the telephone. You will always be called back, and there is a sort of triaging, or people will ring back. There is a triaging opportunity to appraise clinical urgency through that mechanism. But if there is ever an issue in accessing 111, there is always 111 online, which I know a number of cohorts of the population have found very helpful. Especially when we think about some of the calls that might go through to 111 about maybe running out of medication and those sorts of things that could be offered through the online line 111 online offer.
That isn't really a satisfactory answer, because many of these people will be elderly and not have access to the internet or know how to use 111.
And I recognise absolutely we are working with 111 to establish what more can be done to support. We are looking to ensure that they've got access to all the relevant information in terms of single points of access and other vehicles available to them, additional clinical assessment capacity as well. I think there will be peaks and troughs in terms of demand that comes through to 111, and we work very closely with them to make sure that they are planning for the level of demand that is envisaged to come through, so that they can resource the service appropriately. Recognise it won't be a perfect experience for all patients, but we certainly look to provide the best we can and continue to work with SCAS very closely as our 111 provider to support that.
Thank you, Hannah. Would you like to go on now? I think we're on page 23 of 94.
Yes, Chair, certainly. I wasn't going to go into too much more detail about in the rest of the paper. It is largely contextual for colleagues. So again, it's really whether there are any further queries from the committee this evening that anybody wanted to ask.
Does anyone? Thank you. Okay, yeah, thank you.
Sorry, Hannah, I have a few more questions. So in the presentation, there is no mention of increase in radiology or pathology services during winter pressures. Did you consider those?
Yeah, absolutely. So that's all part of a trust's response to planning for the seasonal demand. It gets captured in a slightly different way, but there's been no concerns expressed around pathology or radiology capacity. That continues to be planned for and addressed in sort of the usual trust operational arrangements.
Thank you.
Sorry, are there any more questions before we move on to the next item? Sorry, Ingrid, I'd forgotten you. Would you like to come in now?
Mine's only a really short addition. I just wanted to be able to reassure the committee. But first, before I do that, I'm just going to introduce Jonas, who's online. So I don't know, for those that don't know, I am moving on from my position as Director of Public Health in about 3 weeks. And Jonas started last week in a period of handover, and he will be taking on the position as Director of Public Health on an interim basis. So he's here to observe and learn and understand how the processes work in Wokingham. So just wanted to make sure that you knew who he was there online. So what I was just going to add to what Hannah, so you've heard this extraordinary kind of level of planning that goes on across this really broad and complex partnership from the ICB's point of view with all of us there around the table as partners from adult social care, voluntary sector. And that really does happen largely on quite a large footprint, and for us that would be Berkshire West. So I think I was just going to try and complement what you're saying by explaining a little bit of what we do very Wokingham specific and at a very community and neighbourhood level, to make sure that you are also aware of some of that preparation that goes on, so that if anything should happen or if anything changes across winter, that our partners here in Wokingham are ready to respond to that. So we do that through the Wokingham Integrated Partnership, which Helen and I both run and chair. David chairs, and Helen and I support him in that. And every year, annually, we have a winter planning workshop with the partners in our integrated partnership, which is all of the same sort of partners from Hannah's system, but those that are focused much more locally. And there's a real strength of voluntary sector partners in that integrated partnership. So we all came together a few weeks ago now, and what we do is it's a twofold workshop. The first half is that each of the organisations explain their winter planning so that we have everybody informed across the system, and that reaches more of our voluntary sector than the UEC planning might do. So it's much more it reaches more of our local community leaders and partners. And then the second half of that is to really do some scenario testing. So we had 3 scenarios this year where we go around, we really test the bits in between our organisations. So what happens, and we've discussed briefly before, what is the impact of poverty this winter going to be, and how are we going to respond to that as a local community system? What happens when same-day access pressure that Hannah's been talking about? What happens if there's, for example, a respiratory virus in children that really adds on pressure to primary care? How, as a community, could we respond to that to help our residents get the best out of the system that we can? And then we always have a supporting hospital discharge one, but rather than the hospital discharge bit, what can we do our side to ensure that flow of patients back to their home or into another setting is optimised? So we do that, and then we pick up any actions that we think might be necessary to really strengthen what we might be able to do. And a lot of it's anticipatory rather than necessarily putting things in place, but making sure that we are all aware so that we can act quickly. We had the Hardship Alliance there and learned a bit about their work going into winter. There's always a huge emphasis around comms. So we were talking about how you might communicate some of that out to neighbourhoods, communities, residents. So we will have and do have held by the integration team a communication kind of cascade that we can use throughout winter. So if there is something that needs to be communicated out quickly or urgently, or any change, we can do that relatively quickly. We also have a bank of comms from past workshops. So we've got Amit, as you might imagine, doing a video about you know, if you've got a child waiting before you go and see your GP, or any kind of primary care based videos that we are ready to put out at any given moment. So pulling that together and making sure everyone's aware where that is and everyone's on the same page. We did this year note that there have been some changes, and it would be useful for all of our social prescribers and clinical and community navigators to be well aware of everything that's on offer, so that anyone who goes to see them or speaks to them, they all have the same level of comprehensive onward referral and signposting. So that is being organised as we speak. And we do have a new service this year called the Residents Reception, which is going out to communities rather than expecting them to come to the community hub, to the voluntary sector hub. And that is an opportunity for people to get help on a hyper local basis. So we will make sure that that is promoted out to all of the communities that are able to access it. So that was all I was going to say, but I just wanted to reassure you that there was, in addition to some of this really robust system planning, that we have this very local planning that Helen and I lead for Wokingham and our local partners as well. Happy to take any questions, and Hannah and Helen might want to add to that.
Thank you, Ingrid. Rochelle, you have a question for Ingrid.
Yes. What is being done about the fact that a larger number of Berkshire authorities are going 114, almost bankrupt, and how is that affecting social care? Because unfortunately, councils don't have the money to pay for it. So what is being done to make up for that?
Yeah, that's a huge question, and one not helped by, well, maybe I shouldn't say, but one that doesn't look like the recent budget helped our position on that for adult social care either. But I think that may well, I'm not entirely sure. So for us, we are not in a situation where we are planning in a 114 space. So what I guess the question for us as Wokingham is, what effect might that budgetary position of other local authorities in the system, what pressure that might put on to us? And I don't know whether that's something that Hannah has thought of across the system on a broader footprint, or it might be a bit far away from the UEC planning operation.
Yeah, unfortunately, I can't comment on that one specifically, Ingrid, but yeah, I think you're right. It's something that we certainly will need to consider.
Hannah, you had a question as well.
Apologies, Chair. It just occurred as Ingrid was presenting as well, that actually the one thing that I do need to flag as well, it sits slightly outside of UEC per se, but it is a major mitigation to winter pressures, and that is just recognising the importance of the vaccine programme. So again, just to assure you, we have got an extensive vaccination programme in place across the system for flu, COVID and RSV, which is the respiratory viruses that Ingrid's just referred to as well, that we know can impact on particular cohorts as well. So again, it would be remiss of me not to mention the importance of vaccination uptake. And certainly, as I say, we've got an extensive programme to optimise uptake, but all local champions welcome on that one as well.
I can tell you the programme's working. I've had all three.
Excellent.
Helen, you have a question as well.
Yeah, it wasn't so much a question, really, just as an observation. I just wanted to come in on the back of the description that Ingrid gave of the work that we've done through the Woking Integrated Partnership, and particularly the winter planning session that we had. So I felt it was a really valuable session. It was supported by members of Hannah's team as well, who were able to distill some of the information that we've heard this evening into the sort of local context, but also just so valuable to hear from all of the voluntary sector organisations about all of the work that they're doing to help prepare for the winter, and indeed throughout the year, and some real opportunities for us to better align our thinking and our communications in particular through working together in that way. And I think there are a number of actions, some of which Ingrid has already mentioned, particularly around aligned communications, but also aligning the messaging through social prescribing, and really just working together really closely to address some of the challenges likely to be faced by residents over the coming months. So yeah, just really to reiterate what Ingrid had said about the value of that sort of approach at a local level. Thank you.
Thank you, Helen. I'll just say now, in case Ingrid goes, thank you for all you've done for us as the HOSC, and I'm sure I speak for Adrian too, as the previous chair. Thank you. We'll miss you. Welcome, Jonas. Look forward to seeing you. Thank you, Ingrid.
Thank you, Chair.
We're now moving on to item 28, which is page 39 of the agenda. And Alice, the floor's all yours now, please.
Thank you, Chair. The presentation that I'm going to do, I'm sure, Madeline, it's been shared. Do I have to share?
Yes, it has, Alice.
Okay. So I'm going to be talking about the GP Access project that we did. So thank you, Chair, for enabling HealthWatch Wokingham to present this long-awaited GP Access report. As you may be aware, this report is a collaborative work of 3 HealthWatch in Berkshire West. However, I will be sharing the Wokingham findings along with lived experience quotes. Although these findings may be a year old, the feedback about the public access to GP services has not changed. We seem to be still seeing the same thing. So the purpose why we took on this project was because we were receiving feedback from the public that they were not able to see their own named GP. The theme that was developing was that there was limited awareness of the new way of working in the GP surgeries. So our objective was to support GP surgeries to increase awareness and improve their communication with the public through our findings. Raise public awareness about the new way of working and pathway. Increase appropriate access to services and reduce complaints. So what we did was we did focus groups. So we went around Wokingham, we went to Twyford, Woodley, Arborfield, Wokingham itself, and name a few. What we also did was we did online surveys along with focus groups. We also did online focus groups for those who could not attend the other feedback formats as well. So, and we in Wokingham, out of the 3 areas, we received about 238 participants who took part in this project, which I think was really, really positive. And what we saw was there were 130 people through our online survey and 108 through our various focus groups. And and the diversity in the focus groups where we had different backgrounds, age, gender, and disability as well. So it really demonstrated a wide cross-section of the communities. So when we did that, so our findings were that there was difficulty in accessing GP services, appointment shortage. 1 in 3 highlighted they felt this was unreasonable, long waits on the phones, no choice of preferred GP. 1 in 3 again could not see their GP of choice. Participations of caring responsibilities struggled to fit in appointments around their caring duties. We also found that people who were told on the phone that someone would ring them back had difficulty taking up that calls because they had their own, especially if they were in their jobs, they couldn't stop whatever they're doing to take up the call. The other thing is also care navigators. There was no awareness that the receptionists were trained to be triaging. The phone messaging that was explaining the system was too long and wordy. The new system in place like Anima, which the public has not been informed or given any training. We also had feedback that they did not mind the change, however, would appreciate clear and easy read communications. Regarding digital services challenge, patients are currently asked to use more than one app or digital platform to access appointments, information, advice, and guidance, and their records. This can be the NHS app, a surgery app, or other methods. So a decision should be made to reduce the apps, the number of apps and a digital platform for people to use. The other thing is also patients were not consulted regarding these apps when they was pushed out. So the expectation was all could use it easily. There was a big gap, communication gap. I always talk about communication, and that's definitely a big communication gap. There was a perception that GP surgeries and the ICB had communicated these changes. However, the public are still struggling with this communication. Many are still confused with the changes and how effective to navigate them. Overall observation was communication is vital. The new way of working took place in 2020. Some services have changed, others have not, which has caused confusion. Clear, accessible information is easy read form is vital for everything that we do. More infograph materials are needed regarding the roles of the personnel working in the new system. Access to appointments should be reviewed, as not everyone is competent in digital services. Communication to the public cannot be siloed. There needs to be a more coordinated messaging about the new way of working, which requires the support of local authorities and community organizations. More digital cafes are encouraged locally, and communication about the availability of cafes is appreciated. Public needs to be part of the consultation of how this works. And one of the recommendations in our report is using the patient participation group more in each surgeries is a good way of communicating changes. One of the other recommendations is to ask the Bob ICB primary care team to update us with the work they have done on the primary care strategy. Thank you, Chair. I can take any questions if anyone's there for wanting to ask.
Anyone got any questions? Yes, Lou.
I don't know if you've got it to hand, but I would be quite interested in the demographics of the people that responded to the survey.
I'm happy to share with you, and I don't have it here with me, but I can share that with you. Not a problem. I mean, one of the things that's very awareness that we've had is the diverse community was limited in this survey, and we are doing more work with that. But we have gone round. We've gone round in every demographics that we can think of to reach out.
Because again, I'd be interested to know what the difference, I'm thinking of age in particular, and what the differences are in preference, because at the N of 1 recent experience, I was made to go to a face-to-face appointment, which was a complete waste of the doctor's time and my time. So I know there's a demographic of patients who would much rather have a phone call, and yeah,
but
that'd
also
be interesting to see.
But also to share that there have been and a feedback that we've had people with learning disability who wanted a face-to-face have been asked to go and use digital. So
but this is why it was annoying me so much that I was being made to go to a face-to-face. Like, it's not needed. Why don't you just get them to phone me and save that for someone who actually needs a face-to-face? So yeah, the inflexibility is frustrating, I think, for patients as well. So, yeah.
Thank you very much. It's really fascinating to see how the narrative of the problem is that there aren't enough GPs has become embedded in the way in which quite a large number of our residents view the situation, you know, and this kind of almost fetishizing of having, you know, going to see my GP. And I mean, it's extraordinary on the doorstep how strong that is. If you ask people about their sort of priorities locally, whatever, the thing that will always come back is there aren't enough GPs. And I wonder, you know, once it is so embedded, this narrative, how, you know, what's the most effective way of countering it? I mean, presumably there'll be more than one, but, you know, how can we, how can we move towards an understanding for people? And I agree with Lou. I think primarily it is older patients or older residents rather who, you know, have this quite idealized image of what a GP or an encounter with the GP should be like. And the strength of that narrative is really amazing. You know, it can overcome almost any attempt to engage with it or to counter it. So I just wonder what you feel, you know, are ways that we, you know, collectively can counter it.
Thank you. Just to share with you one of the observations that we've had in the previous, if you ever register with a GP, you're always named, you have a named GP. And I think that is what been continuously happening. So, you know, if you, in the beginning, I've always been asked, oh, who's your GP? Or if you fill up a form, you'll always ask that question. I think that's where the pattern has been. So I think we all need to make sure that go back to the public and say that is no longer the system, but the system itself has got to change that. So when it comes to the registration part of it, that has got to be very, very clear. We don't have it. And if you look at your registration form, it does say the name GP.
No, that's a very good point, because you're also, as I say, you're asked for it. Yeah. And so that kind of reinforces the belief that you should have one and you should always be able to, and you should only be able to see that person. So. Yeah.
But I think it also is a narrative that all the surgeries have got to say you may have a named GP, but you know, we're all practitioners and you'll see someone who's on that day. I think this is something, it's a mindset that we all need to make people, you know, accept.
Rebecca.
Thank you, Alice. Interesting, lots of information in here, and lots of things you've talked about are things that I'm sure a lot of us have experienced. Seems to be quite a lot of inconsistencies between surgeries and what actually happens on the ground. You know I have issues with my hearing. I go on my NHS app and half my stuff isn't on there and it doesn't link through from Frimley Park and blah, blah, blah. Anyway, so, and I see at the end, you know, you've got some responses from the health professionals, which are kind of, I wouldn't say they're dismissive, but, you know, they are kind of saying, oh, you know, not enough information. I mean, how are you going to try and make any change with all this information? What can we do with it to try and improve things?
Thank you for the question. One of the things I do think communication makes a big difference. I don't think the system is going to change. We need to improve the awareness of the public of how to navigate this new system. I think that's, but I do also ask that our integrated care board put out more comms in different ways is something that we would like happening. But I'm very, very interested to see what the primary care strategy looks like, because I do think that the public is not aware. You know, I just think things are changing so fast. You know, technology is changing very fast, but we've not allowed the public to catch up. So I do think that, you know, communication, constant communication is the way forward. Because if you really turn around and think about, you know, every system that we come through, changes are taking place. So I just think that we need to slow down a bit, but I don't think that's going to happen because we are in that technological world that is fast pacing. But I think if we are, and I have said in my presentation that I think that's got to be a collaborative working with, you know, council, community organizations and the NHS sharing information about the new way of working, so that so that we can tackle this awareness together is the best way forward.
Thank you, Alice. We've got Rochelle, then Adrian, and then Shahid.
Unrelated questions. There are news reports of GPs who can't find a job, and supposedly we're very short of GPs, and I'm wondering what you want to comment on that. And second of all, you're talking about different ways of doing things. I'd love to have an e-consult on some of these things, but they don't seem to offer me that, or even a doctor or an appointment. It used to be you had diabetes checks every year, and you've got some reviews and things like this. An e-consult would be fine for that, but right now they're giving nothing. Absolutely, positively nothing. They're not saying anything. They're not telling you what's going on, what should you do, what shouldn't you do, to prevent further complications. And this is not just me. There's a number of people that I know that are having the same problems. And it's not one particular surgery or anything like this. What are you doing to push out e-consults, to push out different ways of doing things now, to use technology that we do have to take some of the pressure off of GPs, but also to help the people who need the help that doesn't seem to exist anymore?
Can I respond? Just to share that HealthWatch is the messenger to turn around and be the voice for the public, and it's up to so what we do is we share the information with the service provider. So it's up to it's the duty of care to the service providers to act on it, and it is it's up to HealthWatch to make sure that that's in place. So we will hold the services to account. So our plan is in a year's time to go back and have a look at this. What are the changes that have taken place based on our findings?
Adrian.
Yeah, I wanted to come back on these points around the GP. Since the inception of the NHS, the concept has been that you have a personal GP, and you see that because of the anniversary of the NHS, was it 70 years or 75 years, they showed some black and white films describing the NHS, and it is very much the idea that you have a named GP. I've been very ill over the last 2 years, and every single form I get asks me, from whichever insurance provider you wish to name, asks me for my specifically named GP. So the whole bureaucracy and systems are set up on the basis that a person will have a GP. Now we are moving to a production line process, which is more like a factory. I understand this. When I book an appointment, like I booked an appointment today, I have to book an appointment 4 weeks in advance. If I don't, I won't get one, right? So I booked it now for the 27th of November, and that is to see a nurse. I've no idea who my GP is. I never see a GP. But getting back to this point around GPs, in my view, you get what you pay for. People say to me, Woking Borough, it's got the lowest central funding of any council in the UK in terms of central government grant. I would be very interested, now that we are together with Bob, to see the comparative spend across books, Oxfordshire and Berkshire, to see what is the per head spend. And also, when we see the per head spend, I would be very interested to see how many residents that is actually calculated on. Because when I spoke to the CCG many times, they didn't know about a number of estates that have been built in Wokingham. And I kept saying to them, hey, you know, we've got Woking Medical Centre with 22,000 patients. Now Woking Medical Centre's got 25,000 patients, you know, and it goes on. I was there today. There was a massive queue. There was a massive queue in the pharmacy, and that's 24/7 in that institution. The people working in that institution are incredibly helpful, incredibly flexible, but that institution has got too many patients for that institution. And I believe that it's about funding. I believe unless anybody puts real prima facie evidence in front of me, I believe that Woking is underfunded compared to other areas in the UK. That is my belief. And please provide evidence to contradict me. You know, we've talked many times about setting up potential satellite GP surgeries because we can't afford a GP surgery. So when I spoke to the PPG at Woos Hill, they said, we've been trying for ages and ages and ages to set up a satellite because we have 15,000 patients and we're supposed to have 10,000 patients. But the ICB or CCG or whoever, or the bureaucracy is not letting us set up a satellite. We have a doctor to cover this. We can get premises. We can set it up. You know, it'll cover itself, but we're not allowed. This weekend on Saturday, I opened with Nagy and Rochelle and a number of other councillors a new pharmacy in Winnersh.
Adrian, is there a question in here for
yes.
Alice?
Yes, I want to see the numbers. I want to see the spend per person, and I want to see the numbers.
Alice, I'm not sure that's in your remit.
No.
Would you like to comment?
I was going to just say that, and I think Helen is the best person in this for this conversation, to be honest. And I think I do agree with Adrian. This has been an ongoing conversation about the shortage of surgeries and doctors kind of thing. So, but I think Helen is the best person for that.
Thank you. Hannah, you have a question, and then Shahid, and then Nagy. Hannah? Helen, sorry. Helen.
Sorry, I didn't realise you were coming to me. Yeah, so thank you, Alice, for the report. Obviously, we'd seen it previously, but it's helpful to hear you present it and draw those themes out again. So the ICB has commented on the report as included in the report, and I think in that we said we very much welcome it. The communication recommendations in particular are really helpful in areas that we intend to do further work on as part of the implementation of our primary care strategy. And there's various work. I'm speaking to Sanjay, who is our head of primary care for Berkshire West now, various work going on to sort of absorb the findings of the report and think about next steps. So I know he's continuing to talk to you about that, Alice. I think with regard to some of the detailed points and questions that have come up, I'm not in a position to answer those here and now, but the requests for information could, we would absolutely be able to provide around spend, etc., if the committee were to want to make a further request to the ICB. We do in any case now provide an annual report on primary care to the HOSC, but obviously happy to respond to other specific queries as they come up, but I'm afraid I'm not in a position to answer them now. I do understand though that Sanjay is meeting, I believe, with yourself, Councillor Rowland, again to talk through some of the information that the HOSC would find it helpful to see on an ongoing basis. So that potentially would be an opportunity to pick up some of those themes. But really, it was just to thank Alice again for the report and to reiterate that it's very much welcomed by the ICB, and we'll be continuing to work particularly on those communications piece, talking about the new models of care, how primary care can be accessed, and making sure that we're responding to the concerns that have been raised. So thank you.
Yes, thank you. I'll just confirm I am meeting Sanjay. Shahid.
Thank you, Chair. I think it's probably 2 comments, I would say. Just based on the new system, Alice, which you mentioned. I mean, it's understandable from humanist psychology point of view, there'll be resistance in a way because you have this traditionally one-to-one relationship. I have a named GP. You share, obviously, your personal details with them. Yes, it's on the system somewhere, right? But every time you see, it's a personal relationship you have with GP. And every having someone new every time you go and see, it's not the same thing, right? So you might have a system in place and process in place, but you think about the human psychology, right? It's not easy to accept that they're talking to somebody new and going through the same thing again and again. Another thing is that the system, as Adrian said, is not geared up towards, you've been asked for a specific named GP every form you fill in, but on the other hand, you say you don't have one, right? So I think the two actually don't tally up. They're not aligned. And I think probably it's going to take some time before even people will accept that new way of doing things, to be honest. And I can't see it happening very quickly because that's the way the human mind works, right? It is very difficult to change the mindset of people. It's easier to change the process, but difficult to change the mindset, etc. Secondly, also, I think regarding the GPs, how the new way of working within GP as well. And again, having 2 GPs in my own house as well, having this discussion with them on dinner table, and there is a lot of tension within the system as well, which I was hearing, that they are obviously GPs who go through the particular training, and then they have assistants, I'm calling. I may get it wrong, right? But you probably know the exact name. Assistants who are basically not GPs, but they've got actually done 2 years of training, but they're acting as though they're GPs and providing the service. But then nevertheless, they have to be supervised by the proper qualified GPs. So there's a lot of tension. And if they do anything wrong, for example, anything goes wrong, then actually this person who is supervising, their registration may be called into question. So there's a lot of tension within the system, what I'm hearing as well. So I'm sure that that is being, I suppose, done, internally is being managed somehow. But this is just my observation by talking to GPs and also obviously the other side, which I talked about. But I don't know, do you share that? Is that some truth in that, or is that is alien to what I'm saying? What I'm saying is in.
Can I respond? And just to share that, the new way of working, we did offer an infographic for people to understand what the different personnel that's working in the system. I think that more information about the benefits of having those people would be a better way of understanding. For example, having a pharmacy looking at your medication rather than a GP looking at your medication. I think that is something that we have to make the public understand, because I think that makes a big difference. And every personnel in the system has got their speciality. It's even to turn around and say that having a physiotherapist, at least the physiotherapist, you don't have to wait long for a referral. You're going straight to the physiotherapist. It's just trying to engage with the communication system to share what are the details of why these people are in the system. I think that's where and I think the system went wrong. In 2020, the system was set up, but with COVID and everything, the GP system was working, but the public was not informed about it, and that's why we are having this delayed reaction. So we need to give the public a chance to understand why this new system has been taking place. Because I don't think the system's going to change. Because and I think that is an element. Regarding the people that you're talking about is the physician associate who has come into the system, who are not. They are trained, but they are being supervised. I mean, there's been a lot of controversies, but they also have benefits to it. But that is not my place to respond. To be honest, that is the system that's been taking place. Again, I would say the narrative of the right narrative should be used when it comes to giving information to the public.
Thank you, Alice. Nagi, and then Rochelle.
Thank you, Chair. Alice, the report looks good, but I have a couple of things. So the report doesn't talk about the increase in population Wokingham Borough, as an example, is going to have in the next 5 to 10 years, because it is predicted we are going up with 10% nearly the overall population. So how are we going to, I mean, did we factor that in? And that is from various, I mean, yeah. So, and again, we have elderly residents increasing numbers as well. So I don't see that being mentioned in here. So if you can factor that in and emphasis on it, so that would be great. And another element is about the pharmacy. I mean, a couple of weeks ago, I tried finding a pharmacy in the middle of the night just to help one of the residents, and yeah, I couldn't find one. So I'm not sure if that can be added in as well, but thank you.
Just to share with you that we, as Health Watch, we don't look at numbers. What we try and do is look at themes. And I think people need to understand that we are only responding to based on the themes that is coming up. So, you know, this is how we work. So these are the themes that has come up. And I totally get that we've been hearing since the report has been out, we've had no end of feedback, even though with our respondents who from the service providers have given saying that this report is old. We've still got people giving us feedback that, you know, nothing has changed. We've had constant people saying, oh, who are the care navigators and things. And I think this is something that, you know, I personally think that it is sad how the some of the response was saying that the report was old. But I think we've got a lot of learning to do with this report. We should use this report as a good stepping forward, rather than, you know. So I do get the fact that talking about the population side of it is one of the things, and we are hoping that, you know, the next stage of our reporting will be in a year's time, because I always look at impact. So what does my report, you know, what recommendations has what is the impact of the recommendations that we have put in place? We will review that in a year's time, and I will take on board what you've shared as well.
Rochelle.
As Maggie said, we've been adding a lot of people into Wokingham. There are at least 3 large areas that in the southern part of the borough that may or may not have a GP surgery at all. And when we asked for them, the ICB said, oh, they don't really need one. And I would say that's not the right answer necessarily. Not the residents don't believe that's the right answer. We're going to have an estate of about 4,000 homes. And that will definitely need a surgery, but is it going to happen? I will also say that I had a review of my medication with a pharmacist, and that was fine. It was no problem at all. But looking at all these things, and we're not finding everything that we need. And for instance, I got some vitamins, and it says, look at this, ask your GP how this will affect any of the medications you're taking. Who the heck can I actually ask if I call up the GP? They're, first of all, I'm never going to get an appointment or even a phone consultation, most likely. And I'd be happy to talk to a PA or something, a physician's assistant on these things, but you don't seem to have anybody to call to ask. And so am I doing something that's dangerous? Am I not doing something that's dangerous? You know, it would be nice to know these things, just a simple answer, even if it's a question online, say, can I use this with my thing? And they can send me an answer, you know, email me an answer, but it doesn't seem to be available. So what do we do?
Helen, is that where you wanted to come in?
I think Helen should, because
well, I wanted to come in on the question of population,
yes.
Just to say, I mean, we've discussed this previously in HOSC.
Yeah.
The primary care team continue to engage with the planning team with regard to potential housing developments, and obviously as an ICB we do wider planning around demographic change expectations over the coming years, and I just wanted to say again, you know, detailed questions would need to be directed to our primary care team, but they are working with planning, and we intend to respond to the local plan consultation, which I understand has just been launched. So we'll obviously be picking up those themes in that response. Thank you.
It's gone to the inspectors now. It's not a consultation anymore. It's gone to the inspectors. It's been approved by the borough and it's gone to the inspectors.
Okay, so that's okay. I will pick up with the primary care team. They told me it was I believe a regulation 13 consultation to which they would be, or regulation 19. So I can't remember the number that they would be submitting a response, which I believe is due in mid-November.
That's planning anyway, and we're the HOSC, so our expertise is not there.
No,
Adrian,
that's fine. Thank you.
Adrian, you are next.
Yeah, I mean, you know, in this Woking Medical Centre is supposed to cover the universe, and now it's going to be further estates are going to be built around Woking, which will automatically Woking Medical Centre will be the closest. This is really an untenable situation. So I would like to see, this is a formal request for the ICB to provide details of your plans going forward, because for the CCG, I was asking for about 5 years for their plans and they never provided them. So I'm formally asking you this time.
We'd all like to see that.
Yeah. Adrian, thank you. Marie, was it you that indicated next?
I did hold my hand up, but I'm not sure that I was the next.
Yeah, would you like to go now?
I would, thank you. No, I just wanted to an observation really that the sort of like the strength of people's belief of the importance of that when after the fall of the Soviet Union, I was tasked with a sort of reviewing the polyclinic model. So in Russia, as they do in Switzerland, whatever, and as they started to, but then stopped here, they rather than a sort of, you know, our system, they had one of polyclinics, and it was remarkable that the purpose of the building of civil society and during the transfer, the idea was that the polyclinic model was no longer fit for purpose. But one of the interesting things was the incredible strength of popular affection for and determination to preserve the polyclinics. And it's kind of almost the opposite of what we are seeing here, in that there it was the institution, it was the sometimes like the physical building that people had associated with health, with access, all the things, you know, all the anxieties that we hear around, you know, around the GP surgery. So I think it's again coming back to this importance of narrative, that you know, what can be here ascribed to, you know, the importance of a single GP, and that the number of GPs is a metric for the quality of care. In other circumstances, it was the polyclinics, which, you know, you could argue. I know the name has fallen out of favour in the health system in this country, but you could argue that Woking Medical Centre had the capacity or the potential to become a polyclinic for, you know, for our borough.
Does anyone want to come back on that?
I don't think so. It's my place to say all that.
Oversight on the scrutiny. Sorry.
No? Are there any more questions? We've given you quite a rough ride, you two. I hope you've enjoyed it, the intellectual stimulation. That's my excuse anyway.
I think it's a conversation that's needed. I think, and I also would encourage the host to ask, you know, to question and ask Sanjay to come and talk about the primary care strategy of what is the way forward, because that is your best way of understanding, and so that we all can work together to have the public.
Yeah, I would echo that, because I'm only here in a general capacity today on behalf of the ICB for the meeting as a whole, rather than as a primary care representative. And I know we have had Sanjay attend previously. So it goes back to my point really with regard to their schedule to do an annual report on primary care. But obviously there is a capacity or ability to request further information as required, but formally of the primary care team, whereas today I've only been able to give sort of general feedback on Alice's report.
And I think we all understand that this isn't the end of the matter. It will come back again and we will discuss it further and hopefully we'll make some progress as time goes by. Jonas, I hope you're listening. Okay, thank you very much to both of you for your contributions and to all of you. We'll now move on to item 29, the forward programme on page 83.
Okay, so our next meeting is in January, and currently we have an update from RBH on kind of what's happening or otherwise with the development. We have the Autism Strategy Action Plan. We had an update on that some time ago, so this is kind of the outcomes from that. Primary care, as the chair said, she'll be meeting with Sanjay from primary care and the ICB to talk about kind of the information that would be useful for the host to receive in this area going forward. So hopefully we will also have an update on primary care for our next meeting. Apologies, Alice, I put the GP way of working in January's meeting, where that will be a general health watch update, and we'll have the Q2 KPIs. March is looking quite busy. We've got pharmacy and dental services, the KPIs again, and also health watch. We're still also looking to have an additional meeting in February to look at the items around domiciliary care and the market provision. Did anyone have any comments?
Yeah, I'd like to say thank you to Ingrid as well. Ingrid, you did a great job. Thank you very much.
Thank you, Adrian.
Yes, and thank you all of you tonight. It's been a very interesting meeting, and I think we've explored some really delicate subjects tonight. Thank you all for coming. You've got a list of unscheduled topics at the end of the agenda, which there's no discussion on today, they're just sitting there. Thank you, everyone. Those of you who've got to go home, have a safe journey. Those of you who are sitting at home, well, least said. Good night, everyone.